Module 4, Immunity and Infection. So this time we're talking about multi-drug resistant organism infectious disorders, so MDROs. So some terms to remember. So nosocomial infection. This is an infection that you get in the hospital and you didn't have it before you came in, so the hospital kind of gave it to you. We have contact transmission. This is when a person or object comes in contact with the pathogen. Vehicle transmission, this is an indirect mode of transmission that occurs when a disease-carrying agent touches a person's body or is ingested. Vector-borne transmission, an indirect mode of transmission that occurs when a vector, an organism that transmits a pathogen, bites or infects a person, okay? And lastly, bacterial colonization. So when you hear a patient or a person's, we say they're colonized, it means that there's a presence of a microorganism that has grown and multiplied on the host, but there's no interaction between the host and the organism. So they don't have any signs and symptoms, no immune response of that pathogen. Okay, that means the pathogen has colonized, the host doesn't have any immune response to it. Our first superbug that we're going to talk about is MRSA. So this is Methicillin-Resistant Staphylococcus aureus. And this is the most common multi-drug resistant pathogen that you're going to hear about. Okay, so pathophys, coming in contact with the pathogen, that's all it's going to take. Risk factors is going to be being in the hospital in the last 12 months, soft tissue infection. So if you already have an open wound, you're at high risk for getting MRSA. If you were hospitalized in the ICU, or if you reside in a long-term care facility. So this means if any of these situations apply to you, you have an increased risk of exposure. Invasive procedures, medical devices, like if you have an indwelling urinary catheter or an IV line, those are all portals of entry. If the patient is on dialysis, same thing, portal of entry. Also, if patients have been on long-term broad-spectrum antibiotics, then it can allow bacteria to become resistant to that specific antibiotic. So that's exactly how MRSA came to be. So other factors include people who have a weakened immune system already, like the young children, and then older adults, people who have HIV or diabetes, cancer, congestive heart failure, and any other type of immunosuppression are going to be at risk for getting MRSA. Interestingly, Methicillin-Resistant Staph aureus is not naturally found in the environment, but it's found on humans. On the other hand, Staphylococcus aureus, the regular one, is quite commonly found around us. Both MRSA, MRSA, and Staphylococcus aureus can be found or can live on surfaces, fomites, and on humans for days to weeks. So they have a varying lifespan. So once a person is colonized with MRSA, remember, colonized means that you have it growing on you, but it's not causing an immune response. So technically, it's not really bothering you. They can still have an infection from that colony. So oftentimes you'll have MRSA of the nares in the nose. And if a person is messing with their nose, maybe they're sick, they can actually transfer that to another portal of entry, maybe an open wound, and then you have a wound infection of MRSA. So when you get an infection with just regular Staph aureus, that can range from like minor skin infections, like even pimples that you get on your skin can have Staph aureus in it, abscesses, styes in the eye, impetigo. But methicillin-resistant Staph aureus has more serious infections. So that can cause pneumonia, skin and soft tissue infections, surgical site infections, and bloodstream infections. So it's just another level of infections. So complications, increased morbidity and mortality. So maybe you were already sick, but you get MRSA, but then now you're going to die. It kind of pushes you quicker to the end. Osteomyelitis, that's infection of the bone, toxic shock syndrome, and multi-organ failure, so not good things. Here are some pictures of MRSA infection. We want to make sure these patients are on contact precautions. Okay, contact precautions, so good hand hygiene, gown and gloves. Our next superbug is VRE, Vancomycin-Resistant Enterococci. So remember, we have regular enterococci, and then we have vancomycin-resistant enterococci. So the common theme with all these MDRO is that they are resistant to many antibiotics, making it very, very difficult to treat. Okay, so pathophys for VRE is going to be direct contact from skin or patient care equipment. So you can pick this up without having to touch a person. It can be from the equipment that's been contaminated. So risk factors for VRE are very similar to MRSA. It's going to be prolonged hospital stays, people that have weakened immune systems, like people that are in the ICU or maybe are on chemotherapy. People who have prolonged exposure to antibiotics, especially to vancomycin and cephalosporins, and just invasive procedures, devices, those are all portal of entries. Clinical manifestations are going to relate to wherever the specific infection is located. So UTI, you're going to have all of those signs and symptoms of UTI, peritonitis, bacteremia, and wound infection. So complications is that you'll have vancomycin-resistant Staph aureus. You're going to stay in the hospital longer. You're going to have to get more antibiotics for a longer amount of time. Higher mortality rates, so higher risk for death. It's going to cost a lot of money, so increased cost of hospitalization, and it can also cause endocarditis. So enterococci are the third most common cause of endocarditis, and the reason why that's a major problem is because there is no medication that's been approved by the FDA to treat VRE endocarditis, so that's pretty scary. So for this one, again, you want to do contact precautions, hand hygiene, gown, and gloves. Our next MDRO is Clostridioides difficile, or C. diff. So the pathology on this one is spore-forming bacteria. It can live on surfaces for months, and it's transmitted through the oral fecal route. One of the reasons why hand washing is so important to prevent transmission. So risk factors, use of antimicrobials, so antibiotics, especially clindamycin and C. diff. Clindamycin, cephalosporins, and fluoroquinolones, those are all different antibiotics that when these patients are taking them, you want to think this might end up with C. diff. So just remember that. If you're older than 64, and if you're already immunocompromised, then you're at risk for C. diff. Clinical manifestations, you're going to have diarrhea. It is liquid stool, like this picture shows here, liquid stool. Patients may have fever, cramping abdominal pain. We can do a stool sample. It'll be positive for C. diff. But sometimes patients will be asymptomatic and they'll have no signs or symptoms at all. So because the patient's having just liquid diarrhea several times a day, they can become hypovolemic. Their kidneys can be affected, can cause electrolyte imbalance, low levels of albumin, peritonitis, paralytic ileus, toxic megacolon, can lead to sepsis and eventual death. So what you want to remember about C. diff, again, especially these antibiotics, clindamycin, cephalosporins, and fluoroquinolones, will put the patient high at risk for getting C. diff. We want to make sure the patient's on isolation, contact precautions, so gown and gloves. We don't want to use the hand sanitizer for these patients. We want to do hand hygiene in the sink with soap and water only, because that's the only way to get those spores off of your hands. When we're cleaning down equipment, we should be using these special Sani cloth wipes with bleach. Okay, these aren't the regular ones. These have bleach and they can kill the C. diff. Just a side note for you, if you ever encounter a patient that is C. diff positive. So when you go into the room with your gown and gloves, the reason why you're wearing the gown and gloves, yes, it's to protect you, but you are likely not to be immunocompromised at that point. you are trying to protect the other patients that you're caring for on the unit, because those patients are immunocompromised and you can actually transfer it to one of them. So that is the primary reason for gowning up. So don't think that, oh my gosh, I'm going to get C. diff. Well, it's oral fecal, so as long as you're not eating what you're touching, you're good. But it's really easy to carry something from the room and transfer it to another patient's room. So just be aware of that. Next superbug is Acinetobacter baumannii, or A. baumannii. So in the hospital, we don't say A. baumannii, we just say Acinetobacter. So the pathophys on this one, this bacteria naturally lives in water, soil, on animals and humans. It can be recovered from the skin, the throat, and the rectum. And it's possible it can actually colonize the respiratory tract. Studies have actually shown that vascular catheters and the respiratory tract have been identified as the most frequent source of Acinetobacter bacteremia, so blood infection that originated from those areas. Other risk factors for this: prolonged hospitalization, ICU, prior hospitalizations, if you live in a nursing home, if you have a trach, if you have a central venous catheter, if you're ventilated, if you've got tube feedings. Again, that exposure to antimicrobials. So all of those things leave you susceptible to Acinetobacter. The most frequent clinical manifestation you're going to see is ventilator-associated pneumonia and bloodstream infection. So that's the most common one you're going to find. Complications, again, increased morbidity and mortality, increased ICU and hospital length of stay, and increased ventilator days. So you'll have to be on the ventilator longer. Again, contact precautions. Next is CRE, Carbapenem-Resistant Enterobacteriaceae. So carbapenem is the antibiotic that it's resistant to. So pathophys is going to be direct contact. It can be infected or colonized people, wounds, and stool. So the risk factors, very similar to the others: older adults, recent hospitalization, patients in long-term care facilities, other comorbidities like diabetes, heart disease, renal disease, and any type of indwelling devices that act as a portal of entry. So for the clinical manifestations, it's kind of like for any common infection, so fever, chills, and signs of sepsis if the infection hasn't been controlled. And then complications, high mortality rate, so you can die quicker if you contract this bacteria. Contact precautions, hand hygiene, gown and gloves. Okay, so we're almost done here. We have management of these MDROs, these multi-drug resistant organisms. So surveillance. We need to identify who has it, if there's outbreaks, especially in hospitals. So hospitals have implemented surveillance programs. So when certain patients that meet a certain criteria are admitted to the hospital, then they are tested for some of these MDROs. For example, if the patient came from a nursing home, a skilled nursing facility, then we swab the nares for MRSA automatically. That practice is changing a little bit, but that is just one example. Treatment-wise, we're going to perform diligent hand hygiene, place the patient on isolation precautions, and then provide medication depending on what type of organism it is. Clinical manifestations are going to be general infection signs and symptoms, so like fever, tachycardia, tachypnea, hypovolemia, diarrhea, specific to the organism. Here are all the nursing actions you're going to do, pretty self-explanatory. Wash your hands, give something for the fever, the pain, IV fluids, etc. You can read through that. Teaching contact isolation precautions. So the patient can still have visitors, and when they go home, you just want to teach them the same precautions. They shouldn't be sharing towels, pillowcases. They should be disposing of any, if they have a wound, of all that infectious material. Remember the mode of transmission, so we need to educate them. Take the medications as prescribed, because most likely they're going to be on an antibiotic, so they need to finish that so we don't create more superbugs. Let them know what the signs and symptoms of infection are so that they can report them early if they do experience those. And then sun protection, because a lot of the antibiotics out there have a side effect of photosensitivity. And then here's this table 21.2 from your textbook. It shows all the different types of antibiotics that are used for these MDROs. And these are all contact precautions, so just remember that. And this is another table from your textbook, risk factors for multi-drug resistant organisms. Very similar, but there are some differences there that you may want to note. Before I conclude this section, I just wanted to remind you to review your standard precautions and your isolation precautions. So standard, those are all the things we do for everybody, you know, gloves, hand hygiene, cover your mouth when you cough, cover your mouth when you sneeze, those type of things. That's all under the umbrella of standard. Then we have contact isolation, what we just talked about for those MDROs, so gown, gloves, and hand hygiene. And then for droplet, you know, there's going to be something, any type of respiratory condition that's going to cause sneezing or coughing or spitting or any kind of splash of anything, we're going to want to wear a mask and gloves. And then airborne, anything that flies through the air, little tiny little particles, and then they float around, that's airborne. We're going to need our N95 mask and our negative pressure room. Okay, so remember, negative pressure room, N95, little tiny particles flying around. A positive pressure room is like our regular rooms. And that's just a little review I wanted to go over with you, and that's the end of this module.